Imagine this scenario. You, or maybe someone you care about, has just had surgery. It went well, everyone's relieved, looking forward to getting back on track, but then something shifts suddenly. It's confusing, maybe agitated, or just really out of it. Not just tired from the surgery. It's something else, this bewildering thing called post-operative delirium, or POD. It's like a sudden, intense cognitive storm. And importantly, it's not dementia, though they often get mixed up, which is, well, it can be tragic. So today, our deep dive is all about unpacking this. We're going to explore what POD really is, why it happens, the huge impact it has, not just on patients, but on their families too. And the really key thing, we'll look at how it's often preventable and definitely manageable. It's not something we just have to accept. Okay, so we've set the scene, this cognitive storm after surgery. Let's break it down. What exactly is post-operative delirium?
Right. Well, fundamentally, POD is an acute disturbance. It affects attention, awareness, and thinking cognition generally. It develops fast, like over hours or maybe a few days. And a key feature is that it fluctuates. Someone might seem okay one minute, then really confused the next. It's important to see it as a syndrome, not a disease in itself. It's basically a sign that the brain is struggling. It's failing under some kind of significant physiological stress the body's experiencing.
Okay, that paints the picture from the outside. But what's actually happening inside the brain during this? I mean, what are the mechanics behind this storm?
Yeah, it's complex, and we're still figuring out all the details, but the leading theories point to a few main things. One is neurotransmitter imbalance. Specifically, we often see lower levels of acetylcholine that's crucial for focus and thinking clearly, and maybe higher levels of dopamine. They get out of whack. Then there's systemic inflammation. The body's inflammatory response to surgery can actually cross the blood-brain barrier.
So inflammation isn't just localized, it gets into the brain itself.
Exactly. And that disrupts the brain's normal functioning. And third, there's often an exaggerated stress response, high levels of cortisol, the stress hormone, flooding the system. That also impacts brain function negatively.
Wow. So it sounds like the whole surgical experience itself creates this kind of perfect storm environment for the brain.
It really can, yeah. You've got the trauma of the operation itself, the effects of anesthesia lingering, then there's pain, maybe an infection brewing, or metabolic issues like electrolytes being off. Plus, sleep deprivation is huge in hospitals, right? And just being in that unfamiliar, disorienting environment, it all adds up. And then there are the underlying vulnerabilities, things like advanced age, any pre-existing cognitive issue, even mild impairment or diagnosed dementia makes someone much more susceptible. Also, sensory deficits, like if someone can't see or hear well, being very dependent on others for daily tasks, taking lots of medications. Polypharmacy is a big one. And certain surgeries, like heart surgery or major orthopedic procedures like hip replacements, seem to carry a higher risk.
Okay, so it's triggered by all these factors, but it doesn't always look the same. You mentioned fluctuations, but are there different sort of types?
That's right. We generally talk about three forms. There's hyperactive delirium. This is the one people often picture. The patient is agitated, restless, maybe pulling at tubes, seems paranoid. Then there's hypoactive delirium. This is actually more common, but it's often missed because the person is quiet, withdrawn, lethargic. They might just seem sleepy or depressed.
That sounds easy to overlook.
Very easy, and dangerous because the underlying issue isn't being addressed. And finally, there's a mixed type, where the person fluctuates between hyperactive and hypoactive states. But regardless of the type, the key thing is, it's a medical emergency. It signals something serious is wrong physiologically.
Right. And you touched on this, but let's really focus on the confusion between delirium and dementia. This seems critically important and, like you said, potentially tragic. How do we tell them apart?
Yeah.
What does someone listening need to grasp here?
Absolutely crucial distinction. The number one thing is the timeline and the course. Delirium starts acutely suddenly, hours to days, and it fluctuates, remember. Good moments, bad moments. Dementia, on the other hand, has an insidious onset. It creeps up over months, even years, and it's generally a steady, progressive decline. It doesn't fluctuate wildly hour to hour like delirium does.
Okay, onset and course. What else?
The core cognitive problem. In delirium, the main issue is inattention. Big time. Difficulty focusing, tracking conversations, staying engaged with the environment. In early dementia, while memory is usually the first thing people notice going, attention might actually be relatively preserved initially, and perhaps the most vital difference. Delirium is often reversible. If you find and treat the underlying cause, the infection, the medication side effect, whatever it is, the delirium usually resolves. Dementia, sadly, is not reversible.
But it's not always that clear-cut, is it? You mentioned pre-existing dementia being the biggest risk factor for delirium. What happens when they overlap, this delirium superimposed on dementia, or DSD?
Exactly, and that makes things incredibly complicated. It presents a huge diagnostic challenge. Is this sudden change just the delirium? Or is it a significant worsening of their underlying dementia? Or both? This is precisely why getting a good baseline history from the family or caregivers is absolutely essential. They know the person's normal.
That phrase you mentioned, he's more confused than his usual confused. That says it all, doesn't it?
It really does. It gives clinicians vital context. And what's really concerning is the research now suggesting this connection is a bit of a two-way street. Having an episode of delirium seems to actually accelerate the decline in someone with dementia, can even unmask cognitive problems that were previously hidden, sort of simmering below the surface. So even after the delirium clears, the person's cognitive baseline might be permanently lower. It's a serious insult to the brain with potentially long-term consequences.
Wow, that's really sobering. It underlines how serious this is. Let's shift focus a bit, because delirium doesn't just impact the patient. What about the caregivers, the family? You call them the unseen patient, and witnessing this must be incredibly difficult.
Oh, absolutely. It's profoundly distressing. Imagine seeing your parent or spouse, who you know so well, suddenly become someone completely different. Maybe they don't recognize you, or they're saying bizarre things, convinced they're in danger. They might become paranoid, accuse people of harming them, try to climb out of bed, pull out IV lines. It's frightening to watch.
Yeah.
And it creates this terrible feeling of helplessness.
And I imagine they try to explain this sudden change to the medical staff, right? Trying to say this isn't normal for them.
Yes, they become fierce advocates. They'll say, look, just yesterday he was struck doing the crossword. But sometimes, unfortunately, their concerns might be dismissed, talked up to age or anesthesia or just being in the hospital.
That must be incredibly frustrating.
Deeply frustrating. And it leads to exhaustion, guilt. Caregivers start wondering, did I miss something? Did I do something wrong? Is this permanent? The exhaustion is physical and emotional. Delirium often gets worse at night. We call it sundowning. So caregivers might be up all night trying to calm, reorient, and keep their loved ones safe. It's relentless. And research shows this experience can be genuinely traumatic. Caregivers can develop symptoms very similar to PTSD, intrusive thoughts, anxiety, flashbacks, long after the delirium itself is gone. There's also a kind of grief involved. Grieving the temporary loss of the person they know, mixed with this intense fear that the change might last.
That's such an important perspective, highlighting the ripple effect. Okay, it sounds quite bleak, but you mentioned earlier there's good news. Delirium isn't inevitable. It can often be prevented. Let's talk about that.
Yes, this is the hopeful part. Prevention is incredibly powerful here. And the absolute gold standard for preventing delirium in hospitals is the Hospital Elder Life Program, known as HELP. It was developed by Dr. Sharon Inu, a real pioneer in this field. It's a program using multiple strategies together, targeting the known risk factors. And study after study shows it works. It can reduce delirium rates by up to 40%. That's huge.
40%. And what's striking about HELP is that the strategies seem quite practical, almost common sense, but applied systematically.
That's exactly the beauty of it. It's holistic and non-pharmacological, doesn't rely on drugs. It focuses on things like early mobility. Getting patients up and moving isn't just good for the body, it improves blood flow to the brain, helps with orientation.
Keeps them connected to the world.
Right. Another big one is sleep. HELP protocols aim to protect sleep, minimize nighttime interruptions, maybe use non-drug methods to promote rest. Sleep is when the brain does crucial housekeeping, clearing out toxins.
Like the glymphatic system cleanup crew.
Precisely. And simple things like making sure patients have their glasses on and their hearing aids in and working. Sensory deprivation is a major trigger for disorientation and confusion. So addressing vision and hearing is key.
It sounds fantastic, focusing on these fundamental needs. But you mentioned hypoactive delirium often gets missed. So even with prevention efforts, how do we get better at recognizing it when it does happen? Is underdiagnosis still a big issue?
It absolutely is a major challenge. Delirium fluctuates, remember. So a nurse or doctor might assess a patient who seems fine at that moment, but was actually quite confused an hour before or will be an hour later. That's why using standardized screening tools is so important. Things like the confusion assessment method, the CAM, or the 4AT test. These are relatively quick assessments, often done by nurses, that help systematically check for the core features of delirium.
So more routine screening.
Yes. But even with tools, family input is irreplaceable. They know the baseline. They can spot subtle changes. Listening to the family is a critical part of the assessment.
Okay, so let's say delirium is identified. What's the next step?
Right.
What does effective management look like, particularly focusing on those non-drug approaches first?
Well, the good news is that the same strategies used in HELP for prevention are also the cornerstones of management. You create a calm, quiet environment as much as possible. Reorient the person frequently. Clocks, calendars, familiar faces. Involve the family. Their presence can be incredibly reassuring. And manage the basics. Ensure good hydration, nutrition, manage bowels, address pain appropriately. The main medical goal becomes detective work. Find and treat the underlying cause. Is there a hidden infection like a UTI or pneumonia? Are they hypoxic, not getting enough oxygen? Are their electrolytes off? And critically, review all medications, especially drugs with anticholinergic effects, many allergy meds, some bladder drugs, older antidepressants, and benzodiazepines like Valium or Ativan. These almost always make delirium worse in older adults.
So medication review is huge. What about pain? That seems tricky. You need to treat pain, but opioids can cause confusion.
It's a very careful balancing act. Untreated pain is definitely a delirium trigger, so you must manage pain. But you have to do it cautiously, maybe using non-opioid options first, or the lowest effective opioid dose, and monitoring closely for side effects. And I really need to stress this. Medications like antipsychotics should only be used as a last resort for severe agitation where the patient is a danger to themselves or others.
Not as a treatment for the delirium itself.
Absolutely not. They do not treat the underlying delirium. They just manage the symptoms, basically sedating the patient. And they come with significant risks, especially for older adults with dementia, increased risk of stroke, even death. So use should be minimal, short-term, and only when absolutely necessary. The focus must remain on finding and fixing the root cause.
Okay, this has been incredibly informative. To kind of wrap up our deep dive here, the core message really seems to be that post-operative delirium is this acute crisis for the brain. It's different from dementia, but dangerously linked. But crucially, it's often a solvable problem.
Absolutely. Preventing delirium isn't just about managing a short-term hospital complication. It's really an act of, you could say, neurological preservation. It's about protecting the brain from an insult that can have surprisingly long-lasting negative effects on someone's cognitive health and independence.
So thinking about that, the question for you listening is, how can you take this knowledge and be a better advocate? Whether it's for yourself or for a loved one facing surgery or hospitalization, how can you help ensure that the goal isn't just physical recovery, but returning someone to their whole self, mind included?
And maybe think, too, about what this deeper understanding of delirium means for healthcare systems. How can we better support patient-centered care, empower families, and really tackle this common, frightening, but often preventable condition? It's a vital piece of truly holistic care.